Well, hello, everybody, and thank you for coming to our second installment of our web series. As I'd mentioned in our first one with Tom Corey, we've got a wonderful group of experts that participate in building this fantastic business called BioIQ. These advisory board members come from all walks of life and from all talent areas within healthcare, and we're just happy to share their expertise and their thinking with you. Today, I am joined by two fantastic people. Well, actually, they weren't available. So Eric Dishman and Justin Belante were available. And, and Justin is the founder and president and chief operating officer of BioIQ. A long, long history in the area of diagnostics and understanding the impact of diagnostics on people's health. And Eric Dishman, who's got a fascinating life story. I'm going to let him introduce himself because no one can tell it as well as him. But Eric and I met many years ago when he was a fellow and a vice president over healthcare and healthcare strategies at Intel. And I happened to be running a joint venture that Intel was part of. And we've remained friends and colleagues ever since. And we were so excited when he was able to join our advisory group. And we're really excited he can be here so you all can get exposed to the way he thinks about things and how he thinks about innovative ways of dealing with healthcare. Our topic today is one that I think is really timely and very important, is looking at how healthcare and access, affordability, and especially in the era of COVID, how that's impacting some of our most disadvantaged communities out there too. Maybe how we can be a little more creative in how we approach some of those things. But before we get into that dialogue, let me turn it over to Eric and maybe he can take a moment to introduce himself. Hi, Eric. Thanks for joining us.
Oh, thrilled to be here. Wish I could be with you together, but someday soon, hopefully. So I'm a social scientist by training, and I've had this bizarre career in Silicon Valley working on health innovation and health technology for, good gosh, almost 30 years now. I got an internship working for Paul Allen's think tank while I was in graduate school and ended up working on telehealth companies and independent living technologies for seniors almost 30 years ago. We were a little early and have had this fortunate time. I spent 17 years at Intel, started as a junior researcher and ended up building a business there on health and life sciences. That was a global business. So I really got to see and innovate in healthcare across the planet, which was an amazing thing once you're outside of just the American context. And my most recent experience, I got a call from President Obama about five or 6 years ago that said, we want you to come run this new initiative that's going to build the largest, most diverse cohort ever in the history of the United States and in the world, 1 million diverse people, so that our science can reflect the diversity of the country. And then hopefully the healthcare outcomes, the healthcare innovations that come from that science will be available to all people. So the program's called the All of Us Research Program. I'll talk about it some in the course of our discussion, I suspect. If you guys on the call here haven't joined, go to joinallofus.org and decide whether you want to be part of this lifelong study that's really going to help us transform how we do better prevention, how we get rid of the health disparities, a topic that we're going to talk about today. And it's just been an amazing experience where before COVID, I was traveling around the country, spending time with African-American populations, Hispanic populations, tribal leaders all over the country to address the very issues we're going to talk about today. How do we deal with the disparities? How do we deal with the earned distrust that many communities have about the healthcare system, about getting vaccinated? So it's really apropos for the conversation that we're going to have today.
Absolutely. And what a great background for this topic today in particular. So let me jump into one of the first things that Justin and I were just talking about earlier today as it relates to minority populations and all these issues we're having with vaccine distribution. I know part of what you were doing at the NIH is you were dealing with some of the vaccine early on and trying to understand where you go with it, what's right, what's wrong, and you can do a much better job of describing it, but you were knee deep in it. With the background of the program you were asked to join and lead by President Obama, and seeing how there seems to be some disparity and disparate feelings in the minority communities about trusting the vaccines coming out. I'm wondering if you have any insights around that, the psychology of that, and how you think we might be able to overcome that.
I mean, I think the academic term is vaccine hesitancy. And I have to say that feels like an undercall of a phrase because for a lot of the communities that I've been working with over the last 5 years, it is sometimes outright fear, outright rage, and it's an earned distrust. I mean, we got to understand that for many of these minority communities, they have a historically accurate and earned distrust of, if you think about Tuskegee, where in the name of health research, in the name of healthcare, we gave, especially African Americans in that particular case, a disease to try to understand it. So we've got, a job to do now as we face COVID, and I've been involved with trying to help NIH broadly think about how we're going to deal with this because we've been so effective at recruiting minorities to be part of the All of Us research program. What are the keys to that? Unfortunately, I mean, we're witnessing history repeating itself right now. I looked at the numbers this morning. So far, white and affluent populations are 3 times to 5 times the rate of vaccination for COVID than people of color and poor people in the United States. That's partly a function of vaccine hesitancy. That's partly a function of where we're focusing our energy and our resources to try to get vaccines out. I mean, I have colleagues all over the country. I've been working with a group in LA who are trying to get out and both put the vaccine capacity where people are, which is partly why I'm so happy to work with BioIQ, because you're about distributing diagnostic capabilities to where people are and then making them easy for people to use. That's a key thing for these communities. But then the other part of this is just having direct conversations with people about the past, how the present is different. I mean, in our work, there were kind of 4 things that we learned from community leaders of these minority populations. And they're like, first of all, form real relationships, authentic relationships of value before the crisis hits. And the second thing is you have to acknowledge the atrocities every time. There are many people still alive and or children of people that were harmed in the name of what we did to people. With the Havasupai tribes and a long list that I could list that I didn't even know about myself until I started doing this work. The third thing is to show that it's different today, right? How people are protected today, what legal and practical protections are in place that did not exist when those atrocities were done. And then the most important thing is to include minority people as the majority in the solution creation of what you're trying to do here. So that's how we've been so effective to create the most diverse scientific cohort in history. And a lot of those same principles, I think, apply to what we're trying to do with, addressing vaccines right now.
Wow. I'm wondering, and I've heard you talk about this a bit before too. There is so much that the general population doesn't understand about how minority populations have been treated from a medical perspective and a medical testing perspective. How big of a surprise was that to you? You're so well educated. You've been in the healthcare space for so long. Many of us have. Justin's been in it for 20 years. I've been in it for over 30. You kind of think you get around and you know a lot of things. And then you hear stories like this and you realize you know next to nothing. Was that a huge surprise and shock to you?
I mean, I thought I was educated, but until I met these people and these populations, and some people have heard of Tuskegee and syphilis, and that we gave African Americans syphilis and told them that we were curing and preventing the disease when we were knowingly giving it to them. There's a list of dozens of these kinds of things across many populations. And the sad thing is, while those levels of atrocities are not happening, I met with tribes just a little over a year ago before COVID took away the ability to travel. And they were giving us examples. These are, sovereign nations of people coming onto their land and not even doing basic human subjects and consent correctly that we take for granted now, partly as a result of some of these historical atrocities. So, my first week on the job at NIH, I met with tribal leaders and I'm kind of a conflict avoidant person and we're always trying to help people get along and had this kind of rage. And at first I was very defensive about it. And then I stopped and said to myself, Eric, you've got to listen and learn, right? And this isn't earned distrust. And if we're ever going to earn back the trust of minority populations, we're going to have to learn about it, address it, and address their concerns about the ways in which we're distributing vaccines and messaging. It's really about personalization. And you can't generalize that what you're going to do for African Americans in Arkansas and South Carolina is going to be the same thing that's going to work in LA, right? It's, you can't continue these stereotypes that, all healthcare is local and all healthcare diagnostics and delivery should be local, but our context and our conversations need to be local as well. And that's been the challenge of the All of Us program. How do you do a Framingham heart type study of all health conditions across the entire country and create a sense of locality that this tiny town in Massachusetts did when they, created all the breakthroughs that have helped us with heart disease for at least, white Americans.
Right. Are there, and staying on this particular theme for a moment before maybe we shift to another, and if you don't have an exact web address or something like that, maybe after this conversation, we can get some of that from you and share it as part of this. But are there particular locations, websites that you found particularly useful that folk could go and get educated on these kind of things so that before they just start jumping into solving a problem, they actually understand what the real root of the issues are and why people aren't as friendly or compliant when they come into their neighborhoods, so to speak?
Yeah, I mean, there are some, and we created and borrowed some collateral that, I will happily find for you offline in our own education of ourselves as well as our participants. The participants in All of Us research program are proactive in a way that is also not typical of scientific studies. They're invited to be part of governance at the top levels down to the lowest levels. We give data and information back to them. I, as a cancer patient, I had 9 clinical trials I was in and never received any data back. And I didn't do it for that. I was donating to try to help the future of people with kidney cancer. But you think about it, so much of science has been done in a take relationship. You give us data, you give us biosamples, and nothing's been returned to them directly. We're really trying to change that model. So in the course of that, having to develop collateral in multiple languages that teach people a little about the history so that, you don't just fall into the trap of thinking these people are idiots for not coming and getting a COVID vaccine. It's like, no, they'd be idiots not to be concerned based on what happened to their very family members in the past. And the rest of us who don't understand that and don't know that history, you're just living in different universes. So I'm happy to try to find some of that and get the team to find some of that and link it to here.
That'd be wonderful. I'd appreciate that. Justin, I know for both of us, we're both really nice guys. There's no way we're going to compete with Eric's brain and his experience. So anything you and I say is just immediately going to sound kind of dumb in 3rd grade. But I'm going to throw a question at you here, and we'll try to dig in.
Thanks for the disclaimer.
Yeah.
Lower the expectations. Lower the expectations, please.
We're just pumping you up, Eric. Just pumping you up. You've been in this diagnostic space for 15 years when you first started this company, literally out of your dorm room, right? And going direct to consumer, you've served every type of population there is in their home, in a community center, from the wealthiest to the poorest that you've seen. I'm wondering, as you look at what's happening right now with diagnostics, especially getting to local communities in the home, and looking at some of the minority communities that we serve and others serve out there, what are some trends that you're seeing and some things that are weighing on your mind?
Yeah, it's a great question, Sean. I think when we first started BioIQ, one of the fundamental challenges we were trying to address is just access. And that was that Netflix for healthcare type of model, get a test kit into somebody's home. Like that just solves a big challenge from an access perspective. Not everybody can go to a primary care physician because they don't have one near their home, or they have a job that they can't leave or take time off to, fit within the hours that a primary care physician's available. So part of it was just access and convenience from a consumer perspective of being able to get testing in your home and in hours that are convenient to you. So I think that was, probably the biggest initiative. I think what we learned along the way is it's not just access and convenience, but there's a lot of different workflows that you have to kind of meet for how healthcare is delivered. And as one, more than most, is retail, for example. People go into retail, they go to the store, they go shopping, and that's just part of how consumers live and behave. And so, how do you take those same, challenges of access and convenience and solve those through a retail channel as opposed to just a home channel? So I think that's what we've learned along the way is, there's of course the different delivery models. And then on top of that, there's all the evolving technologies where you can collect a sample at home, send it into a lab, technologies where you can collect a sample at home and get the results right there. And so it's very interesting to see all of this evolve. And, as you have more workflows, more technologies, ultimately it breaks down those fundamental components that drive a lot of disparities in care, which is access and convenience. And outside of that, as Eric said, there's a lot of other complexities beyond just those kind of straightforward consumer logistics, as we would call them, to getting healthcare to people.
Yeah, absolutely.
I mean, Justin, you, if I remember correctly, you founded the company in May of 2005. Is that right?
That's right.
So I went back and looked at my journal because I've been keeping a journal since 3rd grade. So I have my whole 23-year cancer journey as well as my whole career mapped out in a journal. You guys will appear in my journal tonight. Just know that you'll live forever in Eric's journal. I have no children, so I guess I'll give it to my dogs. I'm not sure where it's going to go. But I mean, I do patient advocacy for cancer and kidney patients. And I was thinking, in 2005, I was on a particularly bad round of chemotherapy. It was one that, and immunosuppression, an immune cocktail of like an immunosuppression drug plus chemotherapy plus, if I remember correctly, it was probably the age of interferon, when interferon was supposed to cure cancer. That's what Time magazine said that year. And that cocktail almost killed me. It was one of the literal times where we did it. And I remember I had to go into the clinic for lab work 5 days a week for roughly 5 months. And if I was thinking about if the kinds of bio-IQ capabilities had existed then, it would have been life-changing for me. The patients that I advocate for to this day are given a list. I mean, as a kidney transplant patient 8 years ago, I tried to have my transplant recovery at home. And I was able to get the doctors to do the virtual care. I was able to do, some amount of vital signs capture and those kinds of things at home. But I could never get the lab, quote unquote, right, to send me a kit to be able to do blood draws and urine samples at home. I was looking at your ability, the kidney panel that you have is amazing, right? It would have been game changing for me even 8 years ago. Because when you have that transplant or you're going through a serious chemotherapy round, they give you a list and they're like, don't go to Toys R Us, right? And poor Toys R Us is mostly gone. Don't go to a toy store, don't go to a library, and don't go to a hospital or a clinic, right? I mean, these are the instructions. But then they're like, because you got to do your lab work, you have to come back in 5 days a week. So even 8 years ago, when a lot more technology was available and diagnostic capabilities, I tried to drive my transplant recovery experience. And I just couldn't do it because I had to go into the lab, right? I had to drive to this medical mainframe. My wife had to drive me 45 minutes to an hour and 30 minutes, depending on the traffic from out here in the rural areas to Portland. Go into this environment that was dangerous for me because I had no immune system at that particular point in time. And it was just fascinating to think through how transformative these capabilities already are, but the trajectory going forward for what you're going to be able to do for people and access. We have the same problem, if like the same challenges that you're dealing with bio-IQ, we've had in the All of Us research program, right? We're trying to get people to join a research study where you donate blood and urine. Like these people work 70 hours a week on some job that no boss is going to allow them to go off for a blood draw for 2 hours and a urine sample, right? So we're just starting to explore those capabilities of being to put them in the home and the community. This is partly why I was passionate about working with bio-IQ, because this disruption is 20 years late and it needs to scale everywhere and become the default model of care. You should have to prove that somebody needs to come into the medical mainframe to justify them sending that person there. So I just, it was so interesting as I started thinking about the formation of your company, where I was at Intel. That was also the year I started trying to work with CMS, talk about Tom, as well as Congress to start thinking about changing the paradigm of payment from a visit to outcomes, right? And quit worrying about where the visit was done, and did great results sort of drive. So in some ways it feels like we've come a long way, but in some ways it feels like, gosh, it's not going fast enough yet.
Yeah.
Absolutely. Well, you touched on something you had said to me years ago, and I'll probably have to fess up to people that, well, you eat much healthier now because of your transplant. You and I both had an affinity for McDonald's French fries, and
Yes,
and
I still have
so
it.
you know, so we want to put out there that in health, everything in moderation, including moderation, right? But you made a comment to me in that very rarely is there something truly new in healthcare. It's just that its time has finally come.
Mm.
But also, obviously, there are new inventions and new things too. You just touched on one. This business, BioIQ, it's been around for 15 years. And yet most everything in the diagnostic space works like it did 25, 30 years ago. Are you seeing things not just in diagnostics, but just with all your experience? Are you seeing any key things that you go, well, this has been around for a long time, but I think its time has finally come and people will think it's new, even if it's not? Or is there anything out there that you actually believe is truly new, that people ought to know about, whether it's related to COVID or not?
I mean, it's partly the function of where I've worked, because I worked for a lot of my career before I had the focus on the business and driving revenue and all of that, right? I was in research labs. So at Intel, I was in the research labs working for Paul Allen. It was, his think tank was supposed to look far out. So, you're talking to somebody whose job was look into the future and start working on it now and try to make it happen. So in a certain sense, it's hard for me to see things that are new. I think we're still in the infancy of the use of consumer and mobile devices compared to where we could get to. At Intel, I formed a friendship, and Andy Grove was my mentor. We both met while on chemotherapy. We both, and then as he went through his Parkinson's experience, my little team at that point, buried in the bowels of a research lab at Intel, built this wearable device so that Andy and his doctor could monitor his tremor 24/7, as opposed to traveling to the clinic to do these artificial tests that measure tremor, right? And I don't know that he did this. He wasn't supposed to, but I'm quite sure that Andy used this prototype device to actually find the times during his week where he was the most capable, both mentally and physically. And that's when he would do his hardest work for the board of Intel while he was still on there, right? So, the fact that now we're able to start to monitor tremor across a lot of consumer devices, and it's accurate and scientific enough for a lot of purposes, is great. So I think you still have to celebrate the fact that some of things become real and at scale, even though the original idea is really old. So I think some of those that are coming to fruition is, I still think we're in the infancy of the medicalization of consumer devices and the consumerization of medical devices, and the pantheon of capabilities that are going to be out there for understanding disease and prevention and early detection is only going to go up exponentially. And we've got to make those things interoperable and secure and figure out how to use those in the appropriate ways for the game-changing, early intervention that I think they're there for. Having worked in the tech world for so long, the promise of AI, right, has been there forever. You are, to me, an AI company at a certain level, right? Your sophisticated analytic capability. I personally think one of the most magical things that BioIQ has is your intelligent engagement. Because at the end of the day, the way that we're ultimately going to give people access and affordable healthcare is to prevent disease in the first place for a whole lot of people when we can, and change behavior. You can't change behavior if you treat everybody as one size fits all for your coaching program or for your experience. And you are basically enabling mass customization, right? Which has to happen. So, and I'm a behavioral scientist by training, right? And those early studies I did with medication reminders, with trying to get seniors to be able to take meds, these were dual eligible poor seniors on 9 or more medications a day. We had the technology 25 years ago. It was crude and it would work a lot better today to give them their medication reminders in the voice of a loved one, or in those days, they really wanted Oprah. They probably still do today, right? but it was very different per person, right? But the capabilities that we have as a platform today can allow us to really individualize to a particular person's needs. So how is that person's behavior going to change? So I think the AI and the analytics behind that is becoming finally real. Like AI is becoming useful. It's still pretty much in its infancy in healthcare too, I think, but it's sort of on the way there. And then we have to see whether or not COVID and the disruption that COVID has caused puts us on the path of what I've been calling for 30 years, mixed mode distributed care. It's not that I wanted to get rid of hospitals. It's that I wanted hospitals to be much smaller and stop using them for chronic disease management, right? You probably remember, and Sean, and you and I worked on some of this before, looking at hospital at home models where we saw in Israel, in France, in Johns Hopkins, models where 60 to 70% of care that was done in hospitals could be done better quality, lower cost in a home and community setting, right? So I'm not saying hospitals are going to go away, but they should be used when all other capabilities and healthcare modalities don't work anymore, right? And so it really is, I think, an open question whether the COVID disruption has made virtual and distributed care here to stay in the United States. And I got to tell you, 100 times over the last 25 years, I've thought we're finally there. Telehealth is going to scale. And at this COVID moment, as we're all living in these little video boxes, you know, I think it's finally there. But I can already tell you that I've got groups contacting me to try to help them go get their reimbursement code for their particular virtual diagnostics. And if we go down that path of fighting for a reimbursement code, as opposed to rewiring the healthcare system to say, what's the right time and place that the doctor and the patient in communication with each other can figure out that this care should be done, whether it's diagnostics or delivery of care. Sometimes it's virtual, sometimes it's in person in a primary care clinic, and sometimes it's a bus coming out to the house, and sometimes it's going into the hospital or into a clinic. I'm still not sure that we're going to be there. Because we got to pay differently. And, you know, and ACA started us down the path of trying to think about paying differently and pay for value. Every time a telehealth startup or comes to me, it's like, oh, can you help us fight for our reimbursement code? I'm like, you may win the battle, but you're going to lose the war, right? Because if you're fighting for your little niche of a reimbursement code, the healthcare system is not being redesigned enough to say, mixed mode care is right. Sometimes the phone is the best way to do it. Sometimes a video conference is the best way to do it. Sometimes a visit, sometimes a van roll, and sometimes you need to travel to a hospital or a clinic. So, I mean, sorry to get so passionate about it, right? But it's like, you know, the patients that I see as a patient advocate, the, you know, 500 or 400,000 or so participants who have joined the 1 million person, you know, program of all of us deserve to have a healthcare system that is personal and flexible for their needs, and they all deserve to have access and affordability. And so, you know, I don't willy-nilly, you know, partner with companies or go spend my time with companies. I mean, I think what BioIQ has, particularly around intelligent engagement, has the potential to really drive access and affordability, because you're going to finally create the experience that is important for that individual to be able to get over the hurdle of taking the vaccine or getting that diagnostic done. And they can do it on a weekend as opposed to their, you know, 9 to 6 job where they would never be able to get off work. So it's all connected up in that way. It's about personalization and about distributedness. I mean, that's what Andy Grove and I sat down with napkins years ago, and we're like, got to move from mainframe healthcare to personal distributed healthcare. And I think that's some of the capabilities that you really have, or that are empowering for it.
I think that's really well said. You know, a question for both of you before we wrap up here in a bit. Back to your comment about telehealth. It's such a hot topic today, right? And while everything starts with a diagnostic test, so now I know where I'm at with whatever I'm trying to look at. I may not go into my doctor's office, but I need to have an appointment. And trying to tie in this being culturally sensitive, right, and ethnically sensitive. You know, I've worked with and talked to a lot of different telehealth companies, and you know, their idea of customizing for these minority populations is, well, we'll just have an African American doctor on there if they're an African American, or maybe I'll find a Hispanic nurse if they happen to be Hispanic. And you know, to your point earlier, you can be Hispanic in Chicago, and have little to nothing in common with someone who is Hispanic in Louisiana, other than you might speak that same language potentially, and probably not the same dialect if you actually understand how regional things are. Do you, either of you, have any experience or opinions on how you look at how telemedicine actually personalizes itself more towards these minority populations, so it becomes more accepted and therefore more accessible to them?
Yeah, I mean, certainly on a tactical level, Sean, to that point of, using telehealth as a platform that's just connecting doctors and individuals and doing it in a much more consumer-friendly, convenient way, then ideally we leverage that healthcare is local by connecting local providers with local patients and using that platform to do it, as opposed to the mainframe approach, as Eric said, which is, we have a bank of MDs sitting in a sitting in an office somewhere or sitting in their homes in one area of the country, and it's this centralized model. I think, decentralizing, localizing, and using the platform to help do that, as opposed to the platform to kind of centralize and scale it in this uh, uh, basically manufacturing type of mentality.
Yep, yeah, good point. Eric, thoughts?
Yeah, I mean, again, I feel a kinship here to some of the challenges that BioIQ has, just from the work I've done in my time at NIH. What we're finding is, like, even factors like whose device is it that I will be using to interact with the doctor matter, right? And what we're finding is that while many of us may have been brought up to think that, a doctor-patient experience is you going to the doctor by yourself, for some of these communities, sometimes because they have to, because they can't get childcare or other things, but just because of the way that they've been brought up, like this notion of privacy that we try to protect of the individual just doesn't even make sense to them. They're like, no, my mom comes with me to all of my appointments, and this is an open dialogue, and I want her to be there with me. So this gets down to the design of the technology. Is the screen large enough to have two people have a shared experience with the doctor, right? And these sound like little trivial design choices, but we have so designed so much of our healthcare system with a monolithic notion of what the quote unquote average patient wants. There's just no such thing as the average patient, right? I mean, what my mission right now is precision medicine that says, let's stop one size fits all medicine, and let's make sure our science studies all people so that we can develop cures for all people, right? I mean, it's the same thing with regards to these technologies. So many of them have been designed with a particular use case or a particular scenario in mind. So when we went, actually, it's funny you mentioned Louisiana, when we were doing some work in Louisiana and Mississippi, again, before COVID and we could travel, we had built these little booths for you to be able to fill out your surveys for our study and even do a bunch of the interactions right there in this booth. And we would bring these to town, and people loved them because you could do barbecues and events, and then people could go in and do their research study, and we had all these community partners in place. But like, they wanted to bring 2 or 3 family members in there to discuss their health. And so we're like, holy cow, we're going to have to redesign these whole booths. So I think, what we all have to do is just stop to think that our deeply personal way of interacting with the healthcare system that we've learned from somebody else is just our deeply personal way, and it doesn't necessarily scale. And everything from the size of the screen, who owns the device, how are they going to be trained if they're not digitally savvy to do it, has to be taken in. A lot of what I'm working on at the moment is how do we address the digital divide for our participants who aren't going to have and aren't savvy enough to even respond with an email, right? How are we going to address that? So the whole design of the experience needs to change. And that's partly why I still have some skepticism, like, are we there with telehealth? Are we there with analytics? Because if you don't change the rest of the system to sort of orient to personalization, then these will be point solutions in a system that's still wired for mainframe monolithic thinking. So, long live the revolution, and may BioIQ be a key part of driving that. I mean, certainly in the space of diagnostics, things need to move to the home and the community. You've shown that you can drive an out-of-the-box experience that a wide diversity of people can actually use. You're smart about saying sometimes the person can't do it, so we'll help have an employer do it or in a community event. You know, I think those models are affordable for healthcare delivery, not just the diagnostic side of it, but it's going to take a while. We're going to have to pay differently to get everybody to then proactively look at the platforms that could enable that kind of distributedness and personalization. So I know it's doable. We're doing it from a recruitment standpoint. I mean, when I started, I didn't know any better. I was not an academic scholar in this area. One of the first keynotes I had to do as the founding director and CEO of the All of Us program, somebody asked me, what percentage of diversity are you going to go for in the 1 million people? So I thought for a minute and I said 75%. And people in the audience gasped because there were people from NIH and others that knew better, right? And I said, yeah, 75% diverse because we want rural poor and others, right? But I want 50% of those 1 million people to be racial and ethnic minorities. And there, you know, there was just silence and this gasp in the room, and there were reporters starting to write this down. And Dishman says it's going to be, and I was like, uh-oh, I think I'm in trouble. Interestingly, here we are 5 years later. We've been punching around the 80% rate for overall diversity and at about 55% for racial and ethnic minorities. And so I think if you set audacious goals, you allow innovation to happen in small ways and then scale it up for the things that work. And you do it with community partners and with people from the communities themselves, then your success rate will be incredibly high. And I think it's a recipe that's worked for us, and I think it's a recipe that can work for the rest of the system. So, I mean, I'm just appreciative that you're bringing the issues up. More companies need to be talking about it, and you know, we it's shame on us, the American population and culture, to continue the inequities, the disparities that we have inherited. We have the money and the means and the time and the innovation to make affordability and accessibility for all. It is not a difficult thing to do if we just choose to think and act differently about how we go about it.
Well, I can't think of a better way to leave the webinar. I thought that was aptly put. I thought it was from the heart, and I thought it was wholly accurate. And so, as always, Eric, you are a dreamboat of ideas and intellect and experience. And we really hope that the folks that view this on behalf of BioIQ got as much out of it as I know that Justin and I did, and our company will. So thank you very much, and really appreciate your time with us today.
Thank you. Keep up the great work.
Thanks. Appreciate it.